Giving thrombolysis for intermediate risk pulmonary embolisms is commonly practiced, but can this be justified? A pulmonary embolism is defined as a blood clot involving the pulmonary artery. Treatment involves administration of anticoagulation, which helps thin the blood, prevent further clot formation, and allows the body to break down the clot on its own. However, in a select few patients, thrombolysis is required. This involves the administration of medication to dissolve the clot directly. This is helpful as it breaks the clot there and then, but is associated with a much higher bleeding risk. This treatment is usually reserved for patients who are in shock, as defined by having a systolic blood pressure below 90 mm of mercury. So what exactly is an intermediate risk pulmonary embolism? This is defined by the European Society of Cardiology as a pulmonary embolism with imaging evidence of right ventricular dysfunction, cardiac biomarker evidence of right ventricular dysfunction. In practice, this usually means an elevated troponin and the absence of hypotension. Clinicians treating patients meeting this criteria are often unsure on what the correct approach should be. Should such a patient be thrombolized, or should they be anticoagulated? Fortunately, an attempt to answer this question was made in a landmark study in 2015. The study, named as the PITHO trial, compared outcomes for patients who met the criteria for intermediate risk pulmonary embolism and randomized patients to either receiving thrombolysis or just anticoagulation. When comparing patients who received thrombolysis, there was no statistically significant difference in mortality at both 7 and 30 days. More developed both intra and extracranial bleeding. However, fewer patients developed hemodynamic decompensation. Patients from this trial were followed up over a 3-year period. During this time, there was no difference in mortality, there was no difference in functional limitation, and there was no difference in residual pulmonary hypertension, right ventricular dysfunction, or chronic thromboembolic pulmonary hypertension. Administering thrombolysis is costly as it requires high dependency monitoring of patients, and given the lack of clear benefit, the practice of giving thrombolysis in intermediate risk pulmonary embolisms can, as of yet, not be justified.